So if you wanted to go first, Howard.
Okay.
Let's see. There we go.
This is a nice case for David. He's shown this before, but this is such a nice example, I thought I would show another case. So in looking at this frontal projection of the chest, there are a couple findings that allow one to suggest a particular chest morphology. So first, the heart. We see less of the right atrium to the right of the spine than one usually does. So the heart is a little bit pushed leftward, or is located a bit leftward. Then because of that, in part, we see these vessels here very nicely. And although some of this opacity here is obviously due to breast tissue attenuation, perhaps it's more than a bit of that. So you'll see that in a moment. So of course, if I was to make a slab and go to the anterior chest, you'll see the position of the heart. And then going even further, just for fun, you'll see this rather air-filled cleft in front of the heart. And of course, this is a pectus excavatum deformity of the sternum. It is that severe. And of course, we've talked about this before, where we speculate reasonably, I think, that the amount of tissue here that's attenuating X-ray photons because of the deformity is greater than usual. And that may account for some of the opacity that we see on that frontal projection of the chest. So just a straightforward, but rather severe pectus that I think one can readily diagnose, as it were, on the frontal projection of the chest, even without a lateral. David, are you there? You like that?
I love it. Yeah, it was a very nice pectus pseudonemonia.
Yeah, that opacity that we see, which is nice. This one is also back to basics, because the other week, I'm trying to remember exactly what context we talked about pulmonary venous hypertension. So I'll show this case. This is a very nice demonstration of inversion of pulmonary blood flow, cephalization. I usually describe it as inversion of pulmonary blood flow, where in addition to perceiving that the caliber of these vessels is relatively large and these are relatively small, one can actually see two vessel rows parallel to each other. And it's a nice demonstration of the situation where the pulmonary vein is where it should be, which is lateral to the corresponding artery. So left superior pulmonary vein, lateral to the corresponding pulmonary artery. And this person has a huge left atrium mitral valve disease and chronic pulmonary venous hypertension. I want to show you quickly that Leif some time ago shared me this radiographs, this article from the days before CT. So this is in 1968, I think, where a person actually tried to identify and separate the location of pulmonary veins from arteries on lateral radiography of the chest, which of course is not something we usually do. But you can see from this article and these images that he is trying to describe the location of pulmonary veins here. And I will show you that for this particular person, that in looking at the lateral projection of the chest, and I'll mag this up and move it here, that when the veins are so big, we can actually see that. So here, for example, this is the right pulmonary artery, but here's a really nice example of actually seeing a rather dilated superior pulmonary vein on the lateral projection of the chest. And then also we talked about the notion of inversion of pulmonary blood flow being a manifestation of chronic, not acute, pulmonary venous hypertension. So over a long period of time, structural changes occur in the pulmonary vascular bed, particularly in the lower lung zones, such as intimal hypertrophy, hyperplasia, and involving venules, so that the cross-sectional area of the pulmonary vascular bed is reduced, and for that reason, one gets the redistribution of pulmonary blood flow from the lower lung zones to the upper lung zones, and it's chronic and irreversible. So even if the left atrial hypertension is corrected, the structural changes remain. And I think David was referring directly to this article from the Italian investigators who worked with Eric Milne. Those were the guys that worked in part on analyzing the pulmonary blood vessels. So this goes back to 1988, but I just want to go right to the last paragraph of their article, which is pertinent to the notion of this being a manifestation of chronic, not acute pulmonary venous hypertension. So right in there. And that's what I teach. And I think there's a lot of confusion about that point. Is that the article you were referring to, David?
Absolutely.
Yeah.
Very nice case, Howard. So what was the cause of the heart failure in your case?
The left atrium is big. I think this was mitral valve disease. It was a huge atrium. Very large left atrium. I'm trying to remember now. Mitral valve disease. Nice example, by the way, of if you imagine barium going through the esophagus, it would go straight down. Then here it would go this way, and then it would come back. So in the old days, we used to do barium esophagography to look for enlargement of left atrium, and this would produce a beautiful esophagram that would go like that, and then come back. All right, let me show you an interesting case of this one. Here context matters, so this is a post-procedure radiograph. It shows, of course, a lot of subcutaneous emphysema. Pneumomediastinum is present. And then in the upper abdomen, I also discerned air. Then I had to get context. And the context is robot-assisted resection of a kidney lesion. So this is, I believe, capno, not air, but capno, carbon dioxide in those locations as a direct result of that procedure. So of course, there are two possibilities here at least. That is, if some of the carbon dioxide that they introduced to create the space for the lesion resection was in the subcutaneous tissues, that could go up there, of course. But certainly, I think it's quite likely that, and I know by virtue of how much gas they put in reading the op report, that this is in part pneumoretroperitoneum. And certainly air in the retroperitoneal space can certainly go into the chest. So the air could come from this direction, but it could also come from below. So putting everything together, this is very consistent with the sequel of the procedure. But it's carbon dioxide. It's going to reabsorb very quickly. It's going to go away. And by itself, it's not going to cause any harm. And nothing happened to this person. So just a nice observation and putting it together with context. This is a really nice case from Tan Muhammad that I saw he was shared. And I'll put the radiograph up. Now, I don't know the history, but I will readily speculate that in spite of how abnormal this chest radiograph looks, that the patient may have no or minimal symptoms of pulmonary disease. And I'll show you why in a moment I think so. So this, I've seen a number of times. It's kind of a case where it's hard to describe the abnormality other than being very abnormal, but it's pattern recognition. So I don't think we would use easily the word reticular to describe this, although of course you could say, but then you would have to say very large and coarse reticular opacities are present in the lungs, involving all lobes. That's what the projection looks like, which is not itself very helpful. But let me bring the frontal projection back again, and then I will show you the nature of the abnormality, which is dramatically shown by, let me make that go back to what it was before, which is like that, and make this like a bone window. And you'll see that this is what this looks like. And once you see that, you say, bingo, this is a really nice example of diffuse pulmonary dendriform ossifications that are located in the lungs. And what's really nice is to look at the lung windows and see that in between those calcifications, the lungs look all right. So although it's a dramatic image, the lungs in between are just fine. So we've certainly seen that before. And usually I reassure people that this is in effect harmless. It's in this case probably idiopathic. It's not a diffuse fibrosing disorder in this patient that should be associated with symptoms necessarily. And it's a disturbing but otherwise easily explained imaging phenomenon. And this is one of the nicest ones I've seen as well of this entity.
So Jeff showed a bunch of cases that were related to aspiration that were like this, but concentrated in the bases. And you've got a lot of anterior stuff here, so it's not really a very good aspiration distribution. So, you know, so many things can lead to this. Any sort of inflammation can lead to it, and aspiration being one kind of inflammation. And then this one's just kind of out of the blue, and it wasn't amyloid. Was there any biopsy that would have?
Not that I know of. Not that I know of. Not that I know of. Now that you mention aspiration, and again, still don't think this is aspiration, but I actually wonder if there's some airways here. Oh, I can't tell for sure, that might contain some small amounts of material. But I've definitely seen cases that are this dramatic that I just describe as idiopathic. I do see some airways with material in there, but I think that's probably separate from that because the calcifications are everywhere, even though there are some airways, now that I look at it some more clearly down here, that do contain intraluminal material. So while a person actually may be an aspirator, I don't think it accounts for overall what we see. I don't think. We show maybe one more. Let me show you this one. So this is a patient that had a chest radiograph for somewhat unclear reasons. Like you, I'm sure many of your indications probably say SOB, dyspnea, and you look at a radiograph like this and it looks fine except for, and I didn't read this one initially, but there's no diffuse lung disease, but there's an opacity here. So undoubtedly that's not causing whatever symptoms the patient actually has. So the opacity is anterior in the chest, and it is new when compared with the RIP series done years previously. So we know it's a new focal opacity in the anterior and medial right hemithorax, and it is, I'll show you here, located in the middle lobe, the medial and inferior portion of which. So let me switch over to the mediastinal window. It looks like that. There's nothing inside of it. It's just a homogeneously attenuating thing. Its margin with adjacent lung is circumscribed, but a little bit lobulated perhaps. So let's call that an incidental opacity in an 80-some-year-old lady. Here is the PET that shows that this is minimally FDG avid, as you can see there. So very low FDG avidity right there. And then a CT-guided biopsy of it was done, and it turns out to be another case of marginal zone lymphoma as an isolated incidental finding. And that happens. And I always like to think perhaps if that never had been discovered, it may not have done any harm to that patient in that patient's lifetime. It's just, it was discovered and diagnosed as such. And I don't know that they're treating her for this as opposed to just watching it, because I don't think there's disease elsewhere in the body. Just that thing. Oh, there's a few nodes there, but they seem to be rather symmetrically FDG avid and not super hot, so maybe that's unrelated to it.
And this wasn't a Sjogren's.
So no, the lady doesn't have assurance. The lungs look all right. There's one cystic space. If I saw more of those, then I'd wonder. But I don't know what to make of just one little cystic space like that. There. I think she'll be fine. She's an older person. All right, Jeff.
All right. David, do you have cases?
I do.
Do you need a few minutes?
No, I'm ready to go.
All right. I'll give you control here.
So this is a woman who smoked cigarettes, but also worked in construction, a variety of jobs, including, I think, hauling concrete around and stuff like that. And she has these lung calcifications, sort of stringy lung calcifications on both sides with kind of an upper lung concentration, all these little dots. And this is not DPO. This is messier looking than that case that Howard was showing. And some of these are subpleural against the edges here. And I believe that this is low-grade, probably low-grade silicosis from her construction work on sites, breathing some dust like cement dust and things like that. And being around when people were, you know, jackhammering concrete slabs and things like that. So this has worked a long time in construction. Let's look at it in coronal here. It's got that upper lung concentration, including the subpleural stuff that is trying to be pseudoplaque and stuff like that. So I think this is sort of an incidental low-grade silicosis probably in a construction worker.
David, how do you account for the mosaic attenuation? It looks like there's lobular air trapping. Did she have underlying, I mean, at first you were going to tell us this was going to be an HP in construction, but then you showed the denser stuff. But
right. No, I mean, I think she was a smoker, and I think she's probably also used marijuana. She, you know, she doesn't have, you know, she's not is not holding the records for clean living and stuff like that. So, and her history is sort of vague. She's not the world's best historian. So I think it might be her cigarette smoking and what else, you know, other things might have inhaled.
Can you show the mediastinum?
Okay.
I'm curious if her lymph nodes, they don't look, well, can you make it a mediastinal window setting? Yeah, see if her lymph nodes are dense. Not really.
Not that you would be struck by.
Okay.
And modest number of.
Maybe she's got several diseases going on because her lungs in the background look kind of lousy too. Let's see.
Messy. Yeah. Okay, but keep this case in mind. I think it is low-grade silicosis. She's got a larger nodule down there that it didn't want you guys to see. Don't know what to do with that. Okay. And then here's a woman who has CVID. And this is an initial scan that we have on her. I think this is an outside scan. And she's got all of this lung disease really throughout the lungs, somewhat concentrated in the lower lungs. Not really a lot of bronchial disease. Here's a pretty normal bronchial caliber, and it's not a particularly thickened bronchus. First time, you know, I see this widely scattered stuff. I thought, could this be peribronchial disease? But her bronchi don't look all that bad. But she's got all of this stuff. And then on the mediastinal window, she's got a fair amount of lymphadenopathy here. So she got a biopsy. She got a lung biopsy, and this turns out to be GLILD. So she had, you know, granulomatous lymphocytic interstitial lung disease here. And on treatment, this stuff cleared up dramatically. So a follow-up scan done this month or late last month shows almost complete clearing of this. And she never did have the airways disease that I thought might reflect her immune deficiency. So this is GLILD based on biopsy.
And she has a nice big spleen too.
Yeah, that's right. She does have plump spleen, so I think it all hangs together.
Yeah, that's a great case. That's a very good example of it. And would you agree that a lot of the nodules are perilymphatic?
That I think so. You know, if I saw this stuff concentrated in the bases like this, more concentrated in the bases, I think, you know, I've seen LIP variants look like this too. Sort of the nodules, a lot of the nodules are irregular. They seem to be sort of pointing out into interstitium. They get a stellate look and things like that. And so I think this is a lymphatic distribution of these nodules. Okay, so GLILD. Now this woman is from West Africa, is French-speaking part of West Africa, and has lymphadenopathy centrally here, and has this upper lung disease that has a peripheral concentration. And let's look at it here with CT, and it seems to be lots of small nodules, and they have the kind of stringy distribution, again, a lymphatic kind of distribution. They seem to be along fissures here, and I'm not sure how much lymphadenopathy she has at this point. She does have some modest lymphadenopathy, and this is sarcoid. And what struck me about this case is the amount of pseudoplaque, or this peripheral concentration of these nodules along these pleural surfaces here, which I've seen is much more dramatic in silicosis than in sarcoid. But this case really has a tremendous amount of this subpleural concentration here. It's not quite discrete enough that you would start to misinterpret this as plaque. You know, the pseudoplaque looks like plaque because it's got fairly sharp internal margin. This is shaggier looking, but I think this is on, you know, it's in that spectrum of the subpleural concentration that can give you pseudoplaque. So this is one of the dramatic peripheral manifestations and concentrations of sarcoid compared to others that I've seen. Let's see what it looks like in coronography here. Again, it's really hanging along these peripheral pleural surfaces at the lung apices. Yeah. And it's got a nice representation along the fissures too. So sarcoid.
Very nice case.
And so I, you know, if you told me silicosis, I would say lovely. Yeah, I love it. Silicosis, all that pseudoplaque. This one was sarcoid. So things are a bit inverted with the first compared to the first case here, which I think is silicosis. Okay, and then this is a case of a middle-aged guy who has this finding of a calcification down here along the diaphragm, and it's kind of an unusual calcification. It seems to, I mean, it almost looks like rib, doesn't it? I mean, seems to have dense cortex on the edges and then a more lucent center to it. Yeah. Like a piece of bone, huh? So there was a follow-up CT later on, and this sucker is moving around. So now on this later CT, a few years later, you can see that it's shifted locations down here, and it's fatter. It's fatter than the ribs, but it again looks rib-like in terms of having cortex and medulla almost, you know. So it looks like a piece of bone to me. But you know, there's no rib fracture, and all I can do is call this a thoracolith. I mean, this looks like, you know, Jeff, you showed a case I think in 2012 or 2014 of a pleural mouse. Mm-hmm. So this is a pleural mouse, but this is rat-like. I mean, it's larger.
It's a pleural rat.
Pleural rat, and it really looks like bone to me. So I'm, you know. I found this series in JTI of 11 cases, and I was told by one of the residents this morning that on abdominal imaging, you know, the epiploic fat things that can calcify and stuff like that, they often have a rim calcification. So she wasn't discounting the fact that, you know, these thoracoliths are attributed to, one of the considerations is fat necrosis, like the sort of anterior fat near the heart that we see that presents with symptoms that suggest heart, a myocardial infarction or pericarditis, is actually infarcted epiploic fat. She said that in the abdomen, that can have a rim calcification. So she thinks that this rim calcification doesn't exclude this coming from fat. So, you know, the explanation that the authors considered most likely is some fat up here. There's more fat on the left than the right, and there are more thoracoliths on the left than the right. So maybe it's coming from this anterior fat up here that somehow infarcts, calcifies, gets into the pleural space, and then drops into these more dependent locations. So we've got a thoracolith, but the rim calcification is a little bit, gives me a little hesitation to attribute this to something that came from epiploic fat.
That's very interesting. The thoracoliths I've seen before, I think, if I remember, are always, number one, small, and always little round guys.
Yeah, the ones
Right.
the same thing.
Yeah. So perhaps this is a that it is a, maybe it's cartilage or something like that, that a tiny little dot of cartilage that got into the pleural space from an anterior rib or something like that, and then proceeded to grow. I mean, doesn't it look as if it's derived from rib or cartilage? I mean, you know.
Dave, this is Seth. Is it moving? Do we know that this thing is actually freely floating in the pleural space versus matted down?
It is moving, and since this one 3 months later, it's moved even farther medially. So let me show you the original imaging here at the same time, and you can see that it has changed locations. So here's the original one.
All right.
So it is shifted about 20 degrees, and then on the most current imaging, it was not quite such a clean image. It has shifted farther medially now in just the last couple. So it is loose. So.
Okay, we're going to call it a chest rat now.
Okay. Yeah. Okay, those are my cases.
All right. Thank you, David.
Very nice. That's interesting. Please.
Okay, so I'm going to give some follow-up. This was a case that I showed a few weeks ago that Chris Meyer showed me, and at the time we didn't have a diagnosis, but he posited that this patient had a certain diagnosis. So the findings, I'll go over them again, were these sort of basal cysts, many of them perivascular, several nodules in the soft tissues, and then the other finding is this striking bronchial wall thickening, and I'll put on soft tissue window, and you can see it's not only is it thickened, and it is circumferential, so it's involving the membranous portion, but it's also this faint sort of calcification, but did not involve the trachea and main bronchi. So Chris had posited that this was going to be amyloidosis, which is a very good call there. And this is the bronch. So the patient then got a bronchoscopy, and you can see a few images from here. You can see these little submucosal nodules, the thickening of the walls all around, but these submucosal nodules, which are very characteristic of amyloid. You get sort of, and you can see it also with Crohn's disease, where you get these like sort of cobblestoning appearance. And so they did a nice transbronchial biopsy, and you can see, I like the word, lumpy amorphous eosinophilic deposits undergoing cartilaginous metaplasia. And I think that explains some of the calcifications. And then, of course, it was Congo red positive, consistent with amyloid. And they said they could do specific types of characterization, which I think they sent off but aren't back yet. So, but I've never seen a case of tracheobronchial amyloid with parenchymal involvement before. And, and this looks like features of LIP, right, with these cysts, but we know that with LIP, you can get amyloid deposition, and then you can get amyloid without, at least based on your biopsy, you don't see the lymphocytes, you just see the amyloids. But clearly centered around airways as well. I think there's a lot of plugging in here because of the narrowing. But it's a very interesting case. I don't know if any of you ever seen a case of tracheobronchial amyloid with parenchymal involvement.
Yeah, I think I've seen maybe. Yeah.
Okay.
Well, theoretically, I mean, they say that it shouldn't happen. I mean, like all the BU cohorts say that tracheobronchial amyloid occurs without other disease, like it's not associated with systemic disease. I mean, that's what all their literature says from them.
Mm-hmm.
I mean, I don't know if it's some of this is post-obstructive change, kind of like ball and valve mechanism that we see with other diseases, but no. Does he have any like chunky calcified nodules or anything? Or is it just cystic stuff?
No, it's just that, well, there's some calcifications down in there. Yeah, there's actually fairly good calcifications.
Those are often ossification, actually.
That's true. You can get both.
Other thing that, Jeff, if you scroll through the lower lung zones, for example, obviously we see big round cystic spaces, but look at the bronchi, and in some locations, I think that I can see that there is bronchial dilatation.
Absolutely, right here, for example, you can see there's an artery.
Yeah, anterior, right there, you'll see that there's bronchial dilatation.
Right there. Yeah,
in quite a few places.
and I think that may be the post-obstructive phenomenon related to the more central.
That's why yeah, but there's another way that this can work. You know, I have this notion that that paper we wrote about protein deposition in the lung. And when you get deposition of protein in the lung, you can get the formation of cystic spaces. But by the same token, if you have protein deposition related to airway walls by the same mechanism of elastolysis, you can get bronchiectasis. So I view it as all as a manifestation of the protein deposition that occurs in this condition, forming both the parenchymal cystic spaces as well as the bronchiectasis. So I think it explains it very nicely. They just have to make sure she doesn't have a bone marrow and a diffuse plasma cell.
I'm sure she'll get worked up by hematology. Yep. Okay, so this is another case I came across, and we showed these before, but I think there's a good teaching point in here. So I'm going to sort of show the case backwards because I knew what they were looking for, digging around and sort of already have the history. So this is a patient. You can see in the mediastinum we have this soft tissue nodule, which I think for most people would look like maybe a plump left lower paratracheal lymph node. I would agree with that. It looks like it has a fatty hilum. It's a little bigger than its neighbors, but I don't get terribly excited about that. But I do have a neck CT that was done shortly before that shows that this nodule avidly enhances. You still see that center portion not enhancing. So if you look at the other lymph nodes, they don't enhance at all to that degree. So you might think this is a hypervascular lymph node, but definitely it's abnormal because I just don't see, this is a neck acquisition, but you can see we're both on the levo phase and the dextro phase of this. So it's not early or late or anything like that. So there's just a lot of contrast on board. And I've not seen mediastinal lymph nodes enhance that intensely when they're normal. So this patient was being worked up for hyperparathyroidism, and here's the nuclear medicine scan, and you can see there was an area of sestamide uptake in the mediastinum. It localizes, let me move this out of the way here, localized to that area in the mediastinum, which correlates with what we're seeing on both the chest CT and the neck CT. But I went back and looked at some of my other parathyroid adenomas, and I've seen them, several of them on pericardium anteriorly, and I think Travis had a recent one that was not too far away from this area. But I noticed that on the contrasted studies, they all enhanced quite briskly. So that may be a helpful finding in these things. But I think otherwise, I would have thought it's just a kind of a plump lymph node. It's sort of oriented a little differently. Usually they run sort of the long axis follows the long axis of the airways, and this one's more perpendicular to it. There's nothing about this. Even that little lucent center makes it look like a lymph node.
Very nice case.
Yeah. So we don't. I don't think we ever find these prospectively, but it's one of the probably the second most common place I've seen them. I don't know what's published, but the ones I've seen frequently occur sort of in the anterior prevascular mediastinum, right along the pericardium, right up against it. But they can occur anywhere along here. I think there's even one I've seen one written about or described like more posteriorly.
But yeah, I mean that's even in a slightly atypical location. Yeah. I mean, the vast majority of the mediastinum are just sitting right by the thyroid up in the thoracic inlet.
Tracheoesophageal groove area and such, perhaps. Nice case.
Okay, so this is a, let me see, I remember how old. I was middle-aged, I think about 60-something-year-old who was being evaluated for pulmonary hypertension. So sent for a chest CT, has a cardiac history, and so hence the generator in the chest wall. And you'll notice this patient clearly has a smoking history. We've got central lobular, this large paraseptal emphysema, but there's a bunch of other stuff going on, and I'll just let me zip through real quickly. You can see there's bronchiectasis. There's a lot of there's some secretions in the airways, some parenchymal scar, a little cyst here. This looks like a lung cancer in the left lower lobe. A lot of debris in the lower lobe airways. But I want to draw your attention to the trachea. You'll notice there's these funny little ripples in the trachea. The trachea is a little large, but it's not massive. But if I show you on the coronal, sort of the morphology of the trachea, it's got this sort of corrugated appearance with these outpouchings, these sort of diverticula, or at least deep recesses, and these really striking little folds in it. And then you'll notice the main bronchi are quite dilated and have that similar morphology. And they're almost as big as the trachea. And then we sort of taper a little bit and get more conventional bronchiectasis. So I think this is a case of Meunier-Kuhn syndrome, and not so much by the, I mean, the airways are large, but they're not massive, but by the morphology, there's something wrong with the wall of these, that you get these deep recesses and these redundant folds. I'll make a sagittal let's just show you those as well. And on top of this, we've got bronchiectasis, and it's unclear to me, there you can see on the sagittal, these sort of, these little redundant pieces of tissue. It's unclear to me what came first, if recurrent infections led to bronchiectasis and admix that with some obstructive lung disease from smoking to the tracheobronchomegaly, or there's some sort of defect in some tissue. I mean, this is presenting sort of in the mid-60s, some defect in the cartilaginous or other tissues of the main bronchi that lead to weakness, poor clearance of secretions, maybe some malacia. There is a high association with malacia. I don't have expiratory images to see if that was the case, to see if that was contributing, and then led to the infections and the bronchiectasis. And then, of course, we know that's going to be smoking related, probably an adenocarcinoma down there. But I think one thing that's underappreciated in some of the texts is the importance of the morphology, not so much how many millimeters in diameter it is, or how many, at what level, but more when you see this appearance, these redundant folds and these sort of deep recesses in the wall.
Very dramatic, yeah.
Yeah. So I don't know what's going to happen with this patient. I don't know what you can do other than optimize their COPD treatment and secretion management, and then probably not a surgical candidate. So you could radiate the lung cancer. They're probably a stage 1 cancer at this point.
Jeff, if this were small bowel, in my residency days, they called it the stack of coins appearance of small bowel folds.
Yeah.
That's what this looks like, the stack of coins again.
Yeah, that's a good description.
It's interesting that that a lot of that's the posterior membrane that seems to be in those folds. It's not. This is not as if we're bulging between cartilages that gives us outpouchings. It's as if there's something pulling inward, creating those little shelves that stick in from the back wall.
Yeah, and in my readings in the past, I've come across things of deficiency of smooth muscle. There is that thin trachealis muscle, deficiency in elastic tissue, collagen deficiencies. And that's why maybe you also see the scalloping on the lateral walls, the tissue between the cartilaginous rings becomes weak. And you see that bulging or whatever, that sort of corrugated appearance.
It'd be interesting to see how floppy his trachea is when he breathes.
Yeah. It would be nice to see it, but when the history is pulmonary hypertension, we don't usually add expiratory images. There is no mention about anything else in the order at the time. But yeah. Okay, well, those are my cases this week. Seth, I see you're on a web connection. Are you able to share cases or?
Yeah, I think so. If I can get onto it, yeah.
Yeah. All right. Let's see if we can make this work.
Can you see?
I see your screen.
See my screen? Awesome. So,
nobody can see you scream.
what?
Never mind.
Just nice. Again, I thought first, and when I first this case, which was an outside study. So here's the chest X-ray, and was concerned for a right lower lobe mass. Couldn't tell if it was pleural or mediastinal. It really does look extraparenchymal. And they uploaded it outside CT, and when they first opened it, I was wondering if this was going to be the second thymolipoma I've seen, although it doesn't really originate in the region of the thymus or even a teratoma. But this is just a nice example on the other, Morgagni hernia simulating a mediastinal mass. So seen a couple of these now. This one is not too hard to delineate that there's a clear defect in the diaphragm with of mesenteric fat into the belly, but definitely don't want to call a mediastinal mass, because clearly a different method of approach between a incision to fix the hernia diaphragm versus a mediastinal mass, excision which often requires a thoracotomy. So just a nice example of a hernia fake out. This is, if I can get this to pull open. Whoop. Was a guy who and actually a really successful therapy, and he was cancer. But anyway, that he felt SVC, and he underwent a interventional procedure.
Is anybody else here?
Seth?
Seth, I think you're cutting out.
Your audio's behaving badly.
My audio is behaving poorly.
Yeah, it comes in and out a bit. Keep going.
Comes
Maybe
in and out. Okay. Yeah, I'm sorry, guys, if it's bad.
It's okay.
This is a guy who had SVC and was treated interventionally to relieve that. And you can see that the SVC is still quite narrowed. They opened it up a little bit, but the one thing that's interesting that I've never seen before is a clear-cut SVC. So when they went to fix this, they clearly entered into a false channel and dissected through the walls of the superior vena cava to, because what they did is they put a snare into the proximal SVC or a catheter and push to snare it, and by doing that, they actually created an intimal injury into the SVC. So this is the first case of going into the case of a SVC I've seen. I don't know if other people have seen those before, but we thought that was kind of interesting. Can you hear me?
It was intermittent, but we got it. SVC dissection iatrogenic. Yeah, interesting. I've not seen that before.
And then this is pull this over. This is not it's just a nice example of homology. So, this kind of along the pleura and vaginating on the lung, to me, these course along the underlying interstitium of the lung, along the pleural surfaces, very classic looking cyst for bird hog Dubé, and which he has. And then the other nice thing he also has is this renal cell carcinoma, which was a chromophobe renal cell carcinoma. So the case of bird hog Dubé. I tried to do a MIP to see if I could see the fibrofolliculomas on the skin, but I couldn't see them, and supposedly they're very small on him. And then lastly, this is just a very nice example of TB related pericarditis, not a hard diagnosis, really complete invagination, or just the whole heart is basically completely just surrounded by this massive amount of calcification. Very nice is that if you look on CT, not only do you see the extensive calcification and the healed kind of rind-like pleural thickening on the right, which I'm assuming was also due to tuberculosis, but this patient, you don't need a constance. Patient constrictive physiology. You can see that the atria, I mean, these ventricles do not look very happy here. The atria are quite big. Right atrium is quite large, left atrium is quite large, and look at this IVC. I mean, it's two. Just an example of, you know, look at this IVC of just this raging constricted pericarditis. Again, you don't even need contrast. You don't need a gated study, right, to confirm what's going on here. So just, and this was an immigrant from Nigeria who had known exposure to TB that presented with worsening shortness of breath. So just kind of a very classic case of TB just with constriction.
Wow.
That's very dramatic. Wow.
All right.
Yeah. So just a quick run through of those cases.
All right. Well, thank you. All right. Well, unless anybody has anything else, we'll just end a little early today.
I can show one more, kind of a cute. Okay. So let me make that go away. So this case evolved in this fashion. So I was reading this the other day, and I'll show you in a moment that I got lucky, as it were. So I think that what I'm seeing here is not related to the patient's symptoms necessarily, but basically, I initially saw this, which is subsegmental atelectasis, and I'll show you. I'll put the lateral up because I got lucky, and I need to mag this up a bit. And I can't remember whether I saw the thing first on the lateral, then the frontal, but got lucky because on the lateral projection, there is an opacity here, which is different from any of the other opacities one should see on the lateral projection in that location. And then I think secondarily, I said, oh yeah, maybe here there's something round right adjacent to the area of subsegmental atelectasis. So kind of a subtle finding, and got lucky. And I will now show you the thin cuts from the CT that was done subsequently. And here is the lesion. And there are very nice findings here of a post-obstructive phenomenon in the sense that we have mucoid impaction or mucus impaction in some airways. So here, and branching a bit. And then in front, we have adjacent to the atelectasis, subsegmental, we have another bronchus, bronchi filled with stuff, branching. So we have mucoid impaction. And then we can see how nicely this airway leads right into that lesion, and a bit of a so-called iceberg sign, potentially. So a nice endobronchial lesion growing in that location. And then what I didn't, and I looked for it, but I didn't see it initially, didn't catch it initially, but later on, I realized that she indeed had, in a completely different context, this was in the context of a complication of a laparoscopic, I think, a Nissen fundoplication that broke down and did not go very well. So this is some years ago now, and looking for that lesion, whoop, there it is. So one can find it if you know where to look, and it's smaller at the time. So it's grown over time, but slowly. So of course, slow growth, endobronchial lesion over time ought to be what this turned out to be, which is a carcinoid. So a nice example of a carcinoid lesion in the airway, diagnosed via navigational bronchoscopy and a biopsy. So of course it's possible that maybe if it was never discovered, this may not have harmed this person ultimately. May have just continued to grow slowly, but not done very much. Hard to say, but just a nice case of carcinoid endobronchial.
Very cool.
All right.
Yep, very good.
All right. Well, thank you, everyone.
Thanks,
Thank you.
Jeff.
Take care.
Talk to you next week.
All righty.
Bye.
Bye-bye.